Hey guys, welcome back to Coffee Talk with Mike and Janelle. Today we wanted to wrap up a discussion about bipolar. We started last episode, talked a lot about how bipolar presents in folks, what to look for, symptomology. We want to focus a little bit more on the treatment aspect today. So I'm going to let Dr. Cummings delve into different treatment methodologies.
Okay. Well, afternoon, everyone. So bipolar disorder, as Janelle said, we talked about what it was, and just quick refresher. Bipolar disorder is having manic or hypomanic episodes with or without depressive episodes in between. And so it's important when we talk about treatment to talk about the different phases of treatment for bipolar disorder.
Yes.
So first and foremost, if we're talking about bipolar type 1, which means a manic episode, you may present with a major depressive episode, but the cardinal feature is a manic episode. A full-blown manic episode almost always has to be treated in a hospital setting. This is not something you do as an outpatient. This is not something to do. And unlike depression, where you can be treated very effectively with therapies and avoid medications, in most cases, not all cases, typically we use both together. But when we're talking about bipolar disorder, we are really talking about medications when we talk about treatment. Of course, biopsychosocial model, therapies, and environment, and all these other things are important. But we're talking about medications. So, in an acute phase of mania, the treatment of choice really is sleep, is getting someone to fall asleep and get some sleep. Because the cardinal symptom of mania is lack of sleep. There's increased energy and irritability and hypersexuality and all those things we talked about last episode. But is the big reduction or absence of sleep over a prolonged period of time. So anything that makes someone fall asleep will treat their mania. So when we talk about anti-manic drugs, we very often are talking about antipsychotics. The old ones, Haldol, Prolixin, Thorazine, the second generation, Risperdal, Abilify, Zyprexa, Seroquel, there's a bunch of other ones out there. There's some newer ones as well. But anything that makes you fall asleep, that would include Ativan and Klonopin.
Benzodiazepines. Thank you.
Probably not the antihistamines like Benadryl, because why they make people tired to really make them fall asleep, you'd have to take a lot of it. In theory, if you put someone in an ICU bed and intubated them and put them in an unconscious state and woke them up 3 days later, their mania would probably be gone.
That would be an extreme measure, though.
And with a lot more risk and benefit, which is why we would not do that, right?
Okay.
So all antipsychotics are anti-manic, but essentially no antipsychotics are mood stabilizers. So when we talk about mood, there's mania, there's depression, and the word we use in psychiatry is euthymic state. So where you're not happy or sad all the time, but you're at your steady state.
Baseline.
Absolutely all antipsychotics are anti-manic. Very few of them are mood stabilizers. So while they'll bring you down from a manic episode, they won't necessarily protect you from falling back into a manic episode or a depressive episode. When we talk about mood stabilizers, these typically are Depakote, Tegretol, Trileptal, Lamictal. Almost all mood stabilizers are anti-epileptics, so things that we use for seizures. The exception being lithium, which is simply a mood stabilizer. But not all anti-epileptics are mood stabilizers. So usually when new drugs for epilepsy come out, they're often tried for bipolar disorder as well.
That's interesting.
So, and in some cases, we find that they are not particularly helpful. Neurontin, Topamax really aren't helpful in bipolar disorder. Keppra can actually make symptoms worse, particularly in the developmental disability population.
Okay, good to know.
There are a few other medications. You can use certain benzodiazepines for kind of long-term mood stabilization. They're controlled substances. They have risk of abuse.
Addiction.
And there's a huge comorbidity between alcoholism and bipolar disorder. So avoiding things that are controlled substances is something we want to do. And then there's some calcium channel blockers, for instance, that we typically use for blood pressure, can be very helpful as mood stabilizers as well. When someone is in an acute phase, they're probably going to be starting on an antipsychotic. They're probably also going to be started on a mood stabilizer. Mood stabilizers then do, again, keep those ups and downs, but they don't really bring you down from a manic phase. And if they do, it takes a long time as opposed to the antipsychotics. And then they may be given something additional for sleep or anxiety, Klonopin, Ativan, that kind of thing. It's a very difficult thing because being on medications long term, all of these have side effects. But again, it's kind of like akin to being an insulin-dependent diabetic. If you have it, you have to take insulin. If you have bipolar disorder, you really have to stay on your meds, because as we talked last episode, every episode of mania predisposes you to more frequent, more intense episodes. That's that kindling effect that we talked about last episode, and so it's a balance.
So I have a couple questions. It sounds like the goal really here is to bring someone out of the manic state and basically try and level them out, keep them at their baseline. The benzos would be helpful in maybe preventing, another manic episode by helping them sleep more, kind of maintain at the baseline. But you really want to consolidate meds as much as absolutely possible, because there's side effects of all of these medications. I know there's also a depressive side to bipolar. Do you want to speak to that a little bit?
Yeah, I mean, this is a really important topic, because typically with people who have bipolar disorder, we want to avoid antidepressants. Mm-hmm. They have been shown to have the potential of pushing someone into a manic episode. In fact, in the autism population, when we talk about mania, we talk about depression, many of the symptoms are observable, but most of the symptoms are elicited by taking a clinical history from that individual. So if you have someone who is nonverbal or has problems with expressive language, you can't necessarily get to their mood states based on, or someone with significant cognitive disabilities. You can't.
They can't discern
right.
what they're
so
feeling.
We're, exactly. Yes. So we're looking at baselines and patterns of change with their family, with their group home staff, and trying to determine. Often the way that we unmask a bipolar disorder in someone who doesn't use words is either because they've been put on an antidepressant. In the case of autism, a lot of things of autism look like OCD and repetitive behaviors, and the treatment for that is antidepressants. And so they're put on a high dose of antidepressants, and it flips them into a manic stage. The other time that occurs is because the sun actually is a fairly potent antidepressant. Those light boxes actually really do work. Mm-hmm. A lot of people start cycling in the spring because there's more sunlight. It's a natural antidepressant, and they may cycle. And so there are cases where someone has significant depression during a bipolar disorder where we may utilize a antidepressant for a brief period of time, with the idea that as the depressive phase goes away, we're going to pull the antidepressant off. Gotcha. The other treatment that we haven't talked about, and we probably could do, and maybe should do a whole episode on this, that we use for both depression and mania often, and it's actually more effective than any medication, is ECT, or electroconvulsive therapy. But that's probably a discussion to itself.
Yeah, I think that lends to a lot of questions, a lot of concerns just from historical manifestations. But I think it's just really important with the folks that we work with who may not be able to be as expressive as our other, neurotypical folks, that lack of sleep, that maybe increase in agitation or specific behaviors that are indicative of mania are important to just be observable.
Yeah, we see a lot in the autism population, because when we talk about mania in a neurotypical person, we talk about, trying to write the great novel or start a business, all
excessive
these things. Excessive spending.
Yeah.
What we often will see here is kind of repetitive behaviors that are purposefulness, that are not their typical stimming or things. One of the things we see very common is people laying in clothes. Like they'll put more clothes and more clothes and more clothes on.
We've had a few patients with that.
Absolutely. Yes. And so everyone, regardless of diagnosis, regardless of IQ, has a baseline. It may be harder to tease out if there's a lot of internal struggles and problems with transition and problems with sensory issues. If there's a lot of external stressors in a group home or a family home or whatnot, but everyone has a baseline. The diagnosis for bipolar disorder takes a long time in a neurotypical population often. It may even take longer, but it's perfectly possible to make that diagnosis over time when you include the individual, their family members, their treatment team, people around them, and track things over time. And again, we'll go back to this in almost every episode. The diagnosis is really important, because otherwise we're just prescribing meds. And if we don't know what we're prescribing for, you may not get any better, but I guarantee you'll have side effects from them.
Absolutely. And I just want to close with, everything that's happening in that person's world is important, and you need to be mindful of that. Changes could be sparking behavior. Maybe it's an anniversary date of some kind of trauma that person experienced, but the layering of the clothes, nobody ever thought to tell us that was an issue, and it happened to come back to us in a random way, and we finally were able to kind of put the puzzle together and say, this guy is actually having some mania. So
And with the right treatment, this was a gentleman who was going to the hospital twice a week.
Yeah.
And
Yeah.
being very aggressive and doing with the right treatment, he is and has, and knock on wood, been doing wonderful for the last several years with the right treatment. Being able to experience and live his best life and meet his developmental trajectory, which is what it's all about.
Cheers.
All right.
All right. Well, that's it for today, folks. We're out of time, but until next time,
APIC out.
APEC out.